Okay. So good afternoon, everyone. This is a Thursday new meeting for on behalf of the Health Economics Unit. And today, Stephane Hess will be presenting. Is from the University of Leeds and is an honorary professor in UCT here. And he will be presenting on a study carried out in 18 countries, made up of 18 countries, including South Africa. And in terms of the South African component, this is a collaboration between Health Economics Unit and the Engineering Department with Mark. So, Stephane, this is a presentation, is a new meeting in the School of Public Health. We have this every Thursday, and it would be nice for you to share with us what the results are with regards to the path towards herd immunity, predicting COVID-19 vaccination uptake through the use of state choice study across 6 continents. Thank you.
Thanks a lot, Funke. So I only have one condition, that next time I want to do the presentation in person. So I want to go to Cape Town again soon. So great. Yeah. So some of you know about this study. And, you know, the hardest thing with putting this presentation together, Mark, sorry, you heard this joke before when you saw the presentation once before, but the hardest thing with putting this presentation together was the first slide, because on the first slide, I named all the people that were working on it. So I've never actually worked on a paper with 40 co-authors. So there were people across many different countries, of course, Mark, Funke, and Hashvine in Cape Town, Abise in Namibia, and many other great colleagues. So why did we do this study? Well, even though now, you know, times have moved on quite a bit since we started this study, and in some countries, a large share of the population have been vaccinated. You know, in the UK, they're now talking about 2/3 of adults having had both doses. Even so, that's still some way away from reaching levels that are needed for herd immunity. And the problem is that the people that have been vaccinated tend to also be the ones that are most likely to accept vaccination, certainly in the UK, because they started with the older population and the more vulnerable people. Even if we manage to get through this kind of like first wave of vaccination requirements, the need for COVID vaccination is likely not going away. So this virus will probably be with us for a while. So what this study was about is trying to look at how can we predict vaccine uptake, and how might this vary depending on the characteristics of the vaccine, and vary also across countries. Because there's a lot of, there's many news articles, research papers, and so on that talk about the share of people that intend to get vaccinated. And most of these are simple answers to yes/no questions, or, you know, best case scenario, Likert scale question, asking people, you know, how likely are you to accept a vaccine? And a major shortcoming of those studies is that, you know, they're very direct questions, and they also don't actually relate to how the vaccine characteristics might matter for uptake. So depending on what you're being offered, how might that change? And this is very relevant now if you're thinking about the news, talking about efficacy, talking about risk. So if you're thinking, for example, about the UK, so I had the AstraZeneca vaccine. You know, colleagues of mine who are slightly younger, they got the Moderna vaccine and they felt much better than I did after their vaccine. And then in other countries, in Australia, for example, they're refusing to give the AstraZeneca vaccine to the majority of people, and are just waiting essentially for other vaccines to turn up for them. So what we did is, in this study, and I need to keep being careful and not talk about 18 countries, but I got into trouble with Hong Kong, because I was talking about 18 countries, and I was told, well, Hong Kong's not a country. So there's 18 countries, territories, and we used the same survey approach in all of these countries, territories, to try and understand the impact on uptake. And then what we did is we made predictions of uptake in future possible vaccine scenarios, which hopefully I'll manage to do that this time at the end of the presentation, to actually show you the tool where you can play around with it and adjust the levels of the vaccine. So a very large study. So we collected data from over 13,000 individuals in 18 different study areas. There are differences across the study areas in terms of how many people we sampled. So you can see, like the UK, for example, UK and Chile had the largest samples, Some places like Hong Kong and Japan had much smaller samples, and also differences across areas in terms of the timing of the data collection. Some study areas used very representative samples, others did not. So the other thing that we did in all the results I'm going to show you, they're all corrected for age and gender distribution. So to reweight the results to bring them in line with the age and gender distribution in that specific study area. Now, the other thing that's relevant here is there are big differences across the 18 places in terms of how bad the pandemic was at the time the data was collected, and also how in terms of how far along the pandemic they were in that study area. So if you're thinking here, for example, if you're looking at Brazil, in Brazil, the data was collected at a point when they already had a very high cumulative number of deaths per 100,000 inhabitants, whereas Germany and Denmark, and it's a point I'll get back to later on, they were fairly early on in their pandemic, okay? And so numbers of deaths were very low, restrictions were very limited, and as a result, people weren't necessarily as keen on vaccination there as they were elsewhere. And then, of course, for some of these areas, things have changed dramatically, and for others, they have not. New Zealand is still down here. New Zealand has largely avoided COVID. Australia, if you're watching the news, things are not going so great at the moment. So again, things are changing all the time. And what we did later on, and I'll tell you about that in a bit, is how we controlled for that in model calibration when it came to applying the model results. So first, just some background stuff about the data. So people take COVID quite seriously. So we asked them some questions about how likely do you think if you were to get COVID, how likely is it that you get symptoms, serious illness, hospitalization, or in fact that you could die from the infection. And again, this varies extensively across the study areas. In general, one thing that we found, for example, is all the Spanish-speaking countries were the ones where people answered higher risk levels to these questions, which is quite interesting. And then the one on the right is looking at people's estimates of the share of people that have been infected in their country at the time of data collection. This was actually somewhat in line with what was really going on. But then the other one that's interesting is people's estimate of the risk of death if they were infected themselves. And that's where you can see South Africa stands out here with the highest estimate, but then, followed by Spain, which is obviously a very different country with a very different health system. So again, not necessarily correlated with what your a priori expectations might be. Then we looked at the impact that the restrictions have had on people's perceived mental and physical health. Again, differences across countries. One interesting thing is, South Africa got cut off here in the table. But one interesting thing is that in South Africa was the one country where a non-trivial share of people said their mental health was better than before COVID-19. And I remember I was talking with Mark about this at the time. And he echoed this. He actually said that he was actually feeling better because there was less stress. You were just staying home, didn't have to commute. Maybe you didn't have to deal with students quite so much either, Mark. Then differences across countries in past vaccine uptake. So again, big differences across countries. This partly driven by what vaccines are recommended to people, but also what is access to vaccines in different places. And what is the impact maybe of beliefs about vaccination in general? Then one that I think is very relevant if you're thinking about education here, this is where China and Chile stand out in terms of difference in reason for vaccination. So in Chile, for example, we saw 55% of people saying that they would get vaccinated due to contact with an infected person. Well, that's a bit too late at that point. And in China, 70% of people due to appearance of symptoms. Again, you need to get vaccinated beforehand. And then finally, we asked people a very direct question, and these are all expressed in pounds and adjusted for cost of living. We asked them a very direct question, whether they would be willing to pay to avoid a 6 months wait for the vaccine, and how much they would be willing to pay for that. And then if they would be willing to pay an additional amount of money, if that also meant that they would not face travel restrictions, quarantine, etc. And again, you can see that across the different study areas, people do express, in some cases, pretty high willingness to pay for avoiding waiting for a vaccine. These are somewhat correlated with earning potential. So you can see Namibia and South Africa are the lower end here, but they're not necessarily uniquely correlated with that. And they're also not necessarily related to whether healthcare is normally free or not. So, if you're thinking in the UK, everything is pretty much free. In the US, it's not, but they're pretty similar here in terms of the willingness to pay. Okay, so that was the basic background stuff. So now we're going to talk about the main study. So in the main study, we showed people a stated choice survey. I don't know how much you all know about stated choice. I'll just give you some background here. The idea of a stated choice exercise is that you give people hypothetical choice scenarios. So you face them with choices where you as an analyst are in control of describing these settings, describing the levels of the attributes, and that we understand how people make choices in different settings so that we can actually then use that data in a model, which I'll talk about in a bit, to understand the impact of different vaccine characteristics, in this case, on vaccine uptake. Now, what we did in the survey, every person saw 6 of these screens here, and the attributes change across those 6 screens. Each time they were presented with 2 different vaccines, so here just labeled vaccine A and vaccine B, and the option of refusing vaccination. For the 2 vaccines, they had a further 2 options. They had the option of waiting. So in this case here, if you're looking at vaccine A, if you wait for 1 month, you can have that vaccine for free. For vaccine B, which is the slightly better vaccine in this case, you have to wait for 2 months. But for both of them, you could also pay to avoid having to wait at all. Okay. Now, the reason we included paid access is to understand, whether people have a willingness to pay for reducing their waiting time, and it's actually something that is now happening. So in Pakistan, for example, people can pay for access, and there is, you can Google this. There is a surprising amount of vaccine tourism from Latin America to the US. So tour operators organizing trips to the US where you get a vaccine alongside the trip. Okay, so that's what the survey looked like. So if you're thinking about this survey, so people had a choice between 2 vaccines, but each time they could choose between paid and free access and the no vaccine option. And they did that 6 times. Now that gives us 3 possible patterns of choices for people. Either someone can always choose a vaccine across the 6 tasks, so they 6 times choose a vaccine. Maybe they only sometimes choose to be vaccinated and sometimes refuse vaccination, or they never choose a vaccine. Okay, so 3 distinct groups of people. And for that latter group, so the group of people who never choose a vaccine across their 6 choices, we asked them a follow-up question to understand, well, why is it? Why did you never choose a vaccine? And only those people who said to us that they didn't choose a vaccine because the options we presented them with were not good enough for them to be vaccinated. So those people, we considered that they were still open to vaccination if they were being offered the right vaccine. Anyone else, and there were options you could say, well, I don't believe in vaccination and so on. These people were classed as vaccine hesitant. And so that what we've got here, we've got 3 groups of people, essentially. A group of people that will accept any reasonable vaccine, a group of people that will accept to be vaccinated if they're being offered the right type of vaccine, and what defines right is something I'll get to in a bit, and then a group that is unlikely to accept any vaccine. Okay, and it's that middle group that's actually the most policy relevant here, because it's a group that we're trying to understand, well, what will encourage these stragglers to take up vaccination? What kind of vaccine do we need to offer them? Okay, so now if you're looking at the size of these 3 groups, what we can see here is that across all of the study areas, the dark green bar is the overall vaccine uptake. So the overall vaccine uptake is looking across the 6 choice tasks for each person, averaging how many times did someone choose a vaccine, and averaging that across individuals in the data. And you can see that we get very high rates overall of the green bar, but they do vary across countries, okay? And so I already told you, Germany, for example, was lower than we'd expect, but that's because they were early on in the pandemic. Namibia is lower, and that's a point we'll get to later on in the presentation. Now, this doesn't mean, though, that we don't learn anything from these people, because remember, they still have a choice between two different vaccines, and each time paid and free access. So we can still understand, well, which are the important characteristics and how do characteristics influence choices of uptake. And then you can see there's the differently green colored bar here. That's the share that are likely to accept any reasonable vaccine. And the yellow group are the ones that are the most interesting to us, because these are the people who are open to vaccination in theory, but only if the vaccine that they're being offered has the right characteristics. And you can see that overall, that's roughly about a quarter of the people in the data. So when you're thinking about it, they will play a very substantial role in whether or not a country territory reaches herd immunity. Okay, so don't worry, I'm not going to talk in detail about the equations, but it's just to show you that the approach that we used here was a very detailed mathematical modeling for analyzing the choices, and I'm going to tell you a little bit now about that and what we did. So first, if you're thinking about what people faced, they faced 6 choice tasks, each time making decisions about vaccination or not. And so as a first step, we could look at vaccine uptake at the individual level. So we could look at, for each person, what share of their tasks do they choose a vaccine? And obviously that can go from 0 out of 6 to 6 out of 6. And what we use that data for, we use that data in an audit logit model for those of you who are familiar with these models. And we use that to understand the role of country or territory characteristics and person characteristics in explaining the heterogeneity. Okay, so this was a very important part of the analysis that was looking at understanding the differences across countries and across people, which we then used later on in recalibration of the models. So what do we learn here? So first of all, if you're looking at person effects, so this is the impact of gender and education on uptake. And so you can see for most of these, the impact has very wide confidence intervals, okay? And this is something that we're seeing throughout in studies looking at vaccine choices, is that the socio-demographic characteristics of people do not necessarily explain the decisions that people make between vaccination or not. So there seem to be more underlying preferences rather than necessarily linked to things that we observe about them. Having said that, if you're looking at the overall trend on this graph, in general, the likely uptake is lower for women than for men in quite a few areas. And then also education has overall a positive impact on vaccine uptake, except in Hong Kong, which is a huge confidence interval because it's a very small sample, and in Namibia. And maybe that's something that we're going to have a conversation about at the end of the presentation. Then if we're looking at age is the one that's really interesting. So what we did here, we used 45 as the midpoint. So 45 is our base age. And then we looked at how does uptake change for younger people and for older people in a nonlinear continuous specification. And what you can see, with some exceptions, it tends to be the case that uptake is higher for younger people and for older people. Okay, so it goes down in the middle categories. That's not the case everywhere. Okay, so if you're looking at South Africa, for example, South Africa is just below 0 on the left here. So between like the younger ages and 45, not very much changes in South Africa, but then it rises a bit at older ages over here on the right. Okay, then in some other countries, if you're looking at Korea, for example, it goes down with older age. So differences across countries once again. Then we also found an impact of the state of the pandemic. So when people were sampled at a state in the pandemic in their country where there had already been more deaths per 100,000 inhabitants, they were more likely to accept vaccination. So, probably a greater fear factor. And I had another one here, which I'm somehow missing. and the reproduction rate, so the R number, similarly had an impact. So if you were at a peak of the pandemic, so where the pandemic was accelerating in your area, again, that increased your likelihood of accepting vaccination. Okay, so that was the bit, and I see Gloria is in the presentation. Gloria did all of this, all the audit logit analysis, so great work there, looking at understanding how does vaccine uptake vary across countries and within countries. The next step of the analysis takes a very different look. So the next step of the analysis looks not at who chooses what, but why do people make specific choices. So what we're trying to understand there is we're trying to understand the impact of the characteristics of the vaccine on uptake. Because remember, we showed people 6 choice tasks, and we varied what they saw across the 6 choice tasks. So sometimes they were seeing vaccines with higher side effects, sometimes vaccines with greater efficacy, and so on. So what we did, we estimated area-specific latent class nested logit models. So once again, I'm not going to go into the details of the maths here. We did not seek to explain the class allocation of these models. So in a latent class model probabilistically splits people into different classes with different types of behavior. Okay, and given the findings in the audit logit analysis, we did not seek to explain who falls into what class by linking it to social demographics, and I'll get back to that in a little bit. Okay? And what we did in this part of the work is that the people that we had classified as being vaccine hesitant were excluded from this part of the analysis because they were unlikely to accept any vaccine. Okay, so keeping them in the data would not teach us anything about the impact of vaccine characteristics, and would only likely bias those findings in terms of vaccine characteristics. But then what we did, of course, later on in the predictions, because these people exist, they are a non-trivial share of the population, later on in the predictions, we put those people back into the data and predicted their share of the overall sample in a country as well. Okay, so something very interesting that emerges here, and here I'm only showing 16 because Hong Kong and Japan were so small in terms of the sample size that in Hong Kong and Japan we only had a single class model. But in all of the other study areas except Brazil, and I'll talk about that in a second, we found 3 classes of people in the data, plus a 4th group, and the 4th group are the vaccine hesitant people. So what I've got here in each one of these plots is that the last bar is the vaccine hesitant people. So these are the people that we identified in the data as being vaccine hesitant, and they were excluded from the analysis, but then obviously still captured here in terms of what is their role in the overall makeup of a sample. And again, you can see here how that varies across the study area. So, a large share in Namibia, a large share in the US, well documented that the US has a big share of anti-vaccination people. But then what's very interesting is the similarity that we're finding across these 16 study areas in terms of the composition of the classes and the size of the classes. So with the exception of Chile, what we're finding, with the exception of Chile and South Africa, very fittingly, we're finding that the largest class in each study area is composed of people that mainly have a preference for the free vaccine option. Okay. The second largest group is a group that is still in favor of vaccination, but chooses the paid vaccine more often than the first group. Not necessarily choosing the paid vaccine more often than the free vaccine, okay? And then the third group, where it's present, and that third group is not present in Brazil, is a share of people that don't choose the vaccine at all, or very, very rarely, okay? So these different patterns arise across the study areas, but with a strong similarity across the study areas. Okay, and what we put it down in some cases is that certainly in Chile people are very used to paying for access, and that's explaining the results here. It'll be interesting to have a conversation afterwards about why this is also happening in South Africa. So now we have 18 models with hundreds and hundreds of parameters. So I'm not going to show you a table with results, but what I'm going to do is to try and understand the role of vaccine characteristics. We're going to look at marginal effects. So what are marginal effects? Marginal effects are looking at how will uptake change if we're changing a characteristic of a vaccine, okay? And so I'm looking at two separate scenarios in that case. I'm looking at a single vaccine case. So this is a situation where only a single vaccine is being offered, and you have to decide whether you take that vaccine or not. And that single vaccine that's being offered in this base scenario is a low efficacy vaccine, so 60% efficacy for both infection and illness, with unknown protection duration. So you have no idea how long this vaccine is going to work, which is still the truth pretty much. And low levels of mild and severe side effects. Okay. And so then what we're doing is looking at, well, what will happen if I'm changing these characteristics? How will that influence uptake? And the second one is a very interesting situation. So you might think, well, people don't get a choice about what vaccine they get. Well, there are actually some places in the world where people do get a choice between different vaccines. But the other thing is, in some places, people perceive to have a choice, that they maybe have the option of taking AstraZeneca now, or maybe if I wait 2 or 3 months, I'll be offered Moderna or Pfizer. Okay. And so the way we're looking at that is that we now have a situation where there's two vaccines being offered, a low efficacy and a high efficacy one, but the high efficacy one has a 3 months wait. So you need to wait for the high efficacy one. So if we're looking first at the single vaccine case, so the single vaccine case, and looking at, well, what will happen if efficacy increases from 60% to 70%? So if we're able to offer a vaccine that is better at preventing illness, at preventing infection, or at preventing both, okay? So that's what I'm talking about here. The light blue line here is if we're increasing the efficacy against infection. The second one, if we're increasing the efficacy against illness. And the third one, if we're improving both levels of efficacy. And you can see here, now these might seem small percentages, 1.5% extra, but if we're really looking at fine margins and needing to really guarantee as much uptake as possible, these are still very relevant. Then having some knowledge about protection duration is really important. And what I'm showing you here is the light blue bar is if you could tell people that the vaccine is going to protect you for 12 months, as opposed to having no knowledge at all how long the vaccine is going to work, you can see that that has a non-trivial impact on vaccine uptake, going up to close to 5% in quite a few areas. Whereas any additional increase, going from 12 months to 24 months, the benefit of that is much, much smaller. So it's that initial knowing that, hey, this vaccine is actually going to protect me for at least 1 year is worth quite a bit to people. Then if we're looking at side effects, severe side effects matter much more than mild side effects. And what's important here is to realize the differences in scale here. So what I'm looking at, the light blue one, is mild side effects increasing from 0.1%, so 1 in 1,000, to 0.5%, so 5 in 1,000. Whereas for severe side effects, I'm looking at an increase from 0.001, okay, to 0.005. And you can see that the severe side effects have a substantial impact on vaccine uptake. And that's certainly something that is reflected in all the news articles about blood clots and other side effects. People are really concerned about those. Now, what's important here is for most of these, if you're looking back here, we're talking about 2%, 5%, and again, like 2% changes in uptake. Now, what's very interesting is if I'm looking at a situation where there are two vaccines available, but one vaccine, you can get it now, you don't have to wait. And the second vaccine, you have to wait 3 months to get it. But the second vaccine has a higher efficacy. The second vaccine has a 90% efficacy as opposed to 60%. And what you can see happens here, if I am now able to increase the efficacy of the 60% efficacy vaccine by 10%, so up to 70%, you can see that leads to a big shift in people's behavior here, where suddenly far fewer people are willing to wait the 3 months for the better vaccine. So people will then go for the lower efficacy vaccine, but take it immediately. Okay, so this is, a path towards, quicker vaccination rates. This is certainly very relevant. But the other thing that's interesting here is it has little or no impact on overall vaccine uptake, because if you're looking at the red bar here, the red bar is the change in the no vaccine outcome, so people refusing vaccination. So suddenly, if out of the two vaccines that I'm offering, I'm making one of them better, it will lead to a shift between the two vaccines, but it's not necessarily going to really increase overall vaccine uptake per se. Okay. How about if you still have lower efficacy, 60%, but you have some certainty about protection? So you know that the, let's call it AstraZeneca vaccine, is going to work for 12 months, but you have no idea how long the Moderna vaccine's going to work. Then again, you can see a big shift in people away from the higher efficacy vaccine, for which they have to wait 3 months, towards the lower efficacy vaccine, which they can get directly, but which they now also know is going to protect them for at least 12 months. Okay? So once again, big changes in behavior that are apparent here. Now let's think about severe side effects. And this is what's been happening, of course, a lot in the news. So if you're Googling AstraZeneca Australia, so there was a time when AstraZeneca was still being offered to, for example, to healthcare professionals, and there were healthcare professionals in Australia who, even though you'd think, well, they are on the front line, they're exposed more to the virus, even at the time when the virus was pretty low risk in Australia. They were not taking the AstraZeneca vaccine. They were willing to wait for longer to take the lower side effects vaccine. And again, here what you can see is if the lower efficacy vaccine has an increase in severe side effects from 0.01% to 0.05%, again, we're seeing a drop by around 3% in the lower efficacy vaccine and shifting towards the higher efficacy vaccine, but also in that case, some increase in vaccine refusal, okay? Because people are neither willing in that case to take the lower efficacy, higher risk vaccine, nor are they willing to wait the 3 months for the other vaccine. And then, people don't want to wait for so long. So if, for example, here, going back to my base scenario, so again, 60% and 90% efficacy, same side effects, but if the higher efficacy vaccine suddenly had a 6 months wait instead of a 3 months wait, you again see a big shift towards the low efficacy vaccine. So people are willing to wait some time for the higher efficacy vaccine, but not open-ended, of course. Okay, so these are the results from the models per se. So what we did at that point, we went back to the order logit models to try and recalibrate the models, because remember, the data was collected at different points in time. So Germany and Denmark, for example, the data was collected when COVID wasn't so much of a problem there yet. And so the rate of vaccine uptake was lower there than elsewhere. So what we did is we used the order logit model. I'm not going to go into the details of this calibration process, but what we did is we used the order logit model to make predictions for the base data, so the point at where the data was collected in a given study area, and for May 2021, which is when we did this analysis, and for an R number of 1. And then we adjusted the rate of no vaccine choice in the data to reflect the change in the prediction that the order logit was making. So the order logit model was predicting how will no vaccine uptake change if we're looking at the state of the pandemic as it is now and at a reproduction rate of 1. Okay, so we adjusted the latent class results in that way before making the model predictions. And then we looked at a number of different scenarios, and if it works this time, then I'll show you an interactive tool right at the end of the presentation where we can play around a bit with these. So here I'm looking at a situation now of a high efficacy vaccine, 90% with a 3 months wait, versus a low efficacy vaccine with immediate access. So this is similar to what I was showing you in the marginal effects. The difference being now I'm not looking at changes in vaccine uptake, but I'm predicting overall vaccine uptake, okay? And I'm also doing this after calibration of the models. So we've got the dark green line, that's the high efficacy vaccine. Then the more turquoisey one is the low efficacy one, but no wait. Then the yellow one is the no vaccine uptake. So I'll focus on these three to start with, and then we're going to talk about the other ones in a bit. So you can see here that across all of the study areas, except two places, okay, except Brazil and once again Namibia, we're seeing that the low, in all of these other areas, the high efficacy vaccine has a higher rate of being chosen than the lower efficacy vaccine. And certainly in the context of Brazil, what we put this down to is that, in Brazil, the pandemic's been pretty bad. And you're not going to want to wait 3 months. So if you're being offered a vaccine, even if it is lower efficacy vaccine, you're going to go for it, okay? I'm not sure how to explain the results in Namibia. Maybe we can have a conversation about that in a bit. But then you can also see the no vaccine uptake. So this is the yellow bar. Again, big differences across the study areas. So very low in Brazil, okay? And high in Namibia, high in the US, and also pretty high in South Africa. The other thing we did here is I made two additional predictions. So these are the last two lines here. So how about if only the high efficacy vaccine is available, or if only the low efficacy vaccine is available? And you can see if only one of the two vaccines is being offered, we do see a small increase in the vaccine refusal behavior, but not massively so. But it's still, we're still talking a few percentage points in some of the countries. So it's still being able to offer a mix of different vaccines can be beneficial here. How about if we have a situation where the high efficacy one still has 3 months wait, the low efficacy one still has no wait, but it now has the higher side effects. Okay, so we've increased the severe side effects. What you can see if you're comparing these two plots, so the previous one and this one, is that we're seeing a reduction in the uptake of the low efficacy vaccine and an increase in the uptake of the high efficacy vaccine. But still in Brazil, you can still see the low efficacy vaccine still gets the biggest share, even though it has the highest side effects, and that's because you can get it immediately. You don't need to wait for it. Okay. This time we're seeing a bigger impact of a situation if only one vaccine is available. And specifically what I'd like you to do is if you compare the red bar to the yellow bar. So the red bar is a situation where only the low efficacy vaccine is available. And remember, the low efficacy vaccine now has higher side effects versus the situation where you have a choice between the two. And that's where we can now see an increase in vaccine refusal. So there are more people that would simply refuse to be vaccinated if the only vaccine available to them has higher side effects. And then the final scenario I'm looking at is a situation where there is only one vaccine available, which is a high efficacy one, but you have a choice between taking that vaccine for free by having to wait for 3 months, or getting the vaccine immediately by having to pay £100 for it. Okay. And what we're seeing there is that across the different study areas, we're seeing that the dark green bar is the highest, except in Ecuador. Okay, so in Ecuador, we're seeing a slightly higher number of people now choosing the paid option as opposed to the free option. Okay? Now, the other thing that you're seeing here, though, is if I make if I only make the free option available, so if you're comparing this dirty colored bar here to the yellow one, there is not a big change in vaccine uptake overall. But if only paid access is available, you can see that that substantially increases the rate of vaccine refusal in the data. Okay, so now I'm going to try if I can show you this. Let me just move to my browser. Be 1 second. See if this works. Can you see my browser?
Yes, we can.
Okay, excellent. So this is a tool that we put together in Shiny. And so what you can see here, you need to choose a base country, and that's just in terms of the costs. And then we're going to say, let me do this with a plot. So we're going to say, well, I'm looking at having 2 different vaccines available. And I have, one of them is a 90% efficacy. The other one is, in this case, 80% efficacy. Now let's, for both of them, make so the protection here. What are we doing? So we're going to make the waiting time longer. Let's say 6 weeks for the high efficacy one. Both vaccines, we just know that they work for 6 months, okay, and they have the same side effects. And what you can now see is, well, what will happen if I'm changing something? So what will happen if the high efficacy vaccine, if the waiting time increases? So like if I'm going from 6 weeks to 12 weeks, for example, you can see how the dark green bar goes down, okay? So the choice changes between people going for the high efficacy vaccine and the low efficacy vaccine, okay? So I'll later on, I mean, Funke, you can share the slides. I just want to update those graphs where the legend got cut off, but the slides have the link in it, so you can all play around with this. You can also get a table with the same results as the plot, and there are instructions as well, okay? So you can really, in this case, play around with the settings of the vaccines and see what happens. Is there a question? No? Okay, so let me just go back to the slides. So what have we found? So we found that the characteristics of the vaccines matter for a sizable share of individuals. So, there are many people, and, this is kind of reflected if you talk to people, that will accept any reasonable vaccine. And, what defines reasonable is somewhat in the eye of the beholder. And there's a small share of people that will not accept any vaccine. But there is a non-trivial share of people, and, I'm kind of saying probably 25%, that will make their vaccine choices as a function of the characteristics of the vaccine. And what we're seeing is that the characteristics of the vaccine matter, but that how they matter varies across individuals, and it also varies across the different study areas, okay? Interestingly, and I've not gone into that in the context of this presentation here, there are also substantial regional similarities between countries. So, for example, we found very strong similarities between Colombia and Ecuador, but also Colombia and Ecuador were more similar to Spain as well, okay? So there's a cultural link there as well. New Zealand and Australia were incredibly similar, okay? So they're culturally similar, but they've also had a very similar experience with the pandemic. Now, the other point that's very important, and I'm not going to get into the politics of this, but no single vaccine is likely to be acceptable to all individuals, okay? And having more than one vaccine available in a country at the same time may lead to a further small increase in overall vaccine uptake, okay? And there's also a non-trivial share of people that would be willing to pay for faster access. But all that will do is meaning people being vaccinated earlier, as opposed to changing people's choice between vaccine and no vaccine. So how do we use these results? So if you think about herd immunity, what we need to do, we need to convince the group of people who are open to vaccination, in theory, but only if the characteristics of the vaccine are right for them. So you need to ask yourself some very difficult questions here. Should we first use up the lower efficacy, higher side effects vaccine, of which we have plenty? Should we use that up on those people that are willing to be vaccinated anyway, and keep the higher efficacy vaccine for those people that maybe need an additional nudge to be moving towards vaccination, okay? Now that's completely contrary to what's happening in terms of the policy in many countries, where the higher efficacy, lower side effects vaccine is being reserved for younger people because they are apparently more exposed to the severe side effects, but these are the people who would be more willing to be vaccinated anyway. And then the other really very, very difficult point politically is the last point, is that there are major international implications. The countries, everyone seems to be living in silos, completely disregarding the fact that COVID is an international problem. And even if the UK, Israel, and the US vaccinate all their population, COVID is not going to go away for them as a risk. And as Australia has learned in a very bad way now, you can't keep COVID out forever. And so the question becomes here: the vaccine preferences are different across different study areas, different countries, and what we might term optimal distribution of vaccines is not in line with domestic policy and vaccine protectionism. Okay, so maybe the higher quality vaccines at the moment are actually more accessible in areas where there is higher vaccine uptake anyway, and so there could be benefits in making these more desirable vaccines available more in areas with greater vaccine hesitancy. But I'm not going to go into the politics. I'm just a modeler. I don't understand politics. Okay, so thank you. And now, if you can, go and get vaccinated.
Thank you so much, Stephane. The floor is open now for questions. Please, I'm using my phone, so it's a little bit difficult to see the hands. So please, if there are any questions, please jump in. I think in the chat, I could read one out. That's from Leslie. It says, would it not be better to use force of infection, that is more recent waves infections, than cumulative? The current rather than cumulative perception of severity may be more important to predict perception of importance of vaccination.
Yeah, possibly. So what I tried to, this relates to the model calibration and the order logit model. Well, like I said, I didn't estimate the order logit model, Gloria did, but I have all the files, and the last file I used was OL56. So we estimated lots and lots of different models, and we tried many different measures of the state of the pandemic in different countries at the time. So we looked at obviously cumulative number, which is what I used here, the reproduction rate, which I also used here, but we also used how bad was COVID in the week where the data was collected compared to the worst week so far in that study area. Okay, so that was really looking at, are we in a massive peak here in that study area? And none of these worked as well as using cumulative and the reproduction rate. Okay, so again, there's different ways you can try, and it's a case of trial and error what works best.
Thank you. Another question is, choice is also imposed in LMIC countries because of constrained supply. What you can get is what you have received, and there's no clarity on what or when we will arrive on time. So how does that impact on the model? Do you think it has an impact on the model?
Yeah, I mean, look, I think that's, there are huge differences, of course, across countries in terms of what is being offered to people, what are the circumstances, what are the guarantees that you're going to get any vaccine at all. All the model can tell you here is what will happen if a specific vaccine is, or a set of specific vaccines are being made available. How will that influence vaccine uptake? Okay, and of course, all the issues with logistics, etc., aside, and availability, distribution, or something, it will still show you that if you change what is being offered to people, that it will have an impact on vaccine uptake per se.
But okay, so Leslie was talking about the last point, the policy point you mentioned. That is very important. And diversifying vaccine availability in high-income countries, we achieve a modest, if not inconsequential, increase on uptake, while they are desperately needed in the LMIC countries.
Yeah.
So
I have nothing to add to that except that I completely agree with you. It's entirely true, and here they're now talking about giving people, there's so much vaccine availability now in the UK. They're now talking about giving a third dose to people in winter. They're talking about vaccinating children, etc., rather than actually shifting some of the surplus of the vaccine to lower and middle income countries. But let me not get started talking about the Conservative Party.
okay. Thank you. Vanessa asked if the live demo tool you use to show the impact. Please, what software is that?
Very cool. I like
Very
that.
cool.
So basically, all of the modeling that we did was done in R, and this uses a tool called Shiny, and Shiny is free, and it just allows you to basically make R code available online with a graphical interface.
Okay. All right. And Maria said, in choice constraint settings such as our own, preference studies can inform effective communication strategies. To what extent do our current vaccine communication emphasize vaccine characteristics to appeal to people for whom such factors are important?
Yeah, that's an interesting point, actually. And, it's something that, once again, if I had a chance, I would actually try and look at some of these things in the context of the survey. So to really understand what is the impact of messaging on uptake, in terms of how you describe, especially how you describe severe side effects. Severe side effects it's so vague. Well, what is it? Are you going to get, really bad diarrhea, or are you going to get a blood clot? Okay, and so it's communication, I think, is very interesting there. It's something that, not in the context of this work, but in other work I'm involved in, we're actually looking at using stated choice techniques to understand messaging. So to understand how do people react to messages about drugs, in terms of, how do you describe efficacy, how do you describe side effects, etc. Very interesting, because no matter where you are in the world, people do not understand percentages and people do not understand risks. Okay, and so how you communicate those will again have a major impact on people's behavior.
Okay, thank you. There's another question that says that how about health infrastructure available in the public, private sector, and whether that influences uptake? Did we consider that in the model?
No, but one thing, of course, somebody could spend a lot of time trying to understand the regional differences that we're picking up. Are the findings that we're getting in terms of differences? We tried to put the differences in uptake in Namibia down to local beliefs, for example, but maybe there are other reasons for it. Okay, and they again, what you'd really want to do, if you wanted to focus on those kind of issues, what you would probably need to do is do a study where you're doing a survey like this, but then at the same time you do focus groups, follow-up questions, where you really try and understand. All I'm doing here is I'm trying to understand, why does someone choose a vaccine as a function of the characteristics of the vaccine? But maybe the other thing that matters is, why does someone choose a vaccine per se? And also how the characteristics matter for different people across different countries. How is that influenced by the local settings? Okay, so maybe in a country where look here, I'm fairly relaxed knowing that I'm going to be offered a vaccine again, in winter or something like that. So for me, it's all right if the vaccine I'm getting only works for 6 months or 12 months or something. Whereas if I live somewhere where I know, well, look, this is my one shot, my one chance at getting a vaccine. Okay, then I want one that's going to protect me for a long time, because I don't know when I'll get the chance again. And so all those kind of things, I think, are highly relevant, but not something we could look at in the context of this study.
Okay, thank you. Another question is, I'm from Namibia. I arrived late. Sorry about that. That arriving late, but how did you access the survey population, and the fact that the institutional review board can be cumbersome and mediated by the Ministry of Health and Social Services? I think I can answer that. We had a collaborator who is based in Namibia, and he did sort that one out.
Yeah.
Okay, so the other question is, given the study results, what lay public marketing message would you recommend to encourage vaccine uptake for any vaccine?
Yeah, these are tricky questions. I mean, I think what we're certainly seeing here is that the characteristics of the vaccines matter, okay? And, efficacy, side effects, etc. One thing I am wondering here is the way we just let me just cycle back here 1 second. So of course, in everything I've presented here, I've talked about efficacy, okay? But in the survey, we talked about risk of infection. So we presented people with a base scenario. Now, this will happen if you do not take the vaccine. If you do not take the vaccine, you have a 7.5% chance of being infected if you come in contact with an infected person, okay? I think Kari's on the call. I think I got these from Kari at the time. And 20% risk of serious illness if you become infected. And what we then did is, with the vaccines, with vaccine A and vaccine B, what we did is that we looked at, well, how much lower is the risk? And that is obviously, that is what efficacy is, okay? So you can see here for vaccine A has a 90% efficacy for risk of serious illness, because you go from 20% to 2%, okay? But this is much easier, I think, for people to understand. People don't understand risks anyway. They don't understand percentages, okay, anywhere in the world. And so if you're talking to them, well, you're going to get is efficacy is 90% risk reduction. Yeah, but risk reduction from what? Okay, so people need to have a baseline in order to understand these things.
Okay. Thank you so much. Just let's do responding back to Maria. One thing that struck has been the vaccine discourse. Is that before actually having the vaccine, we were preoccupied about vaccine hesitancy. And sorry, because I'm using...
So before we actually had vaccines, we're preoccupied with vaccine hesitancy. Now there's so many studies showing that there is widespread support for vaccination, which is far enough quickly enough. See, this is the bit that I've worried about this, that, look, we've done all this work and is it still relevant? But the numbers that we're talking about, like I said, in the UK now, they say 66% of adults have had 2 vaccines. Well, that's still a lot of adults that haven't. And what they're not talking about per se is uptake. They're saying, how many people have had one. And if you're looking at how many people in theory have been offered one, we're probably still only looking at the moment, even in the higher age groups in the UK, it was probably between 90 and 95% vaccine acceptance, okay? Which is not that different from what the model is predicting here. And that's in the older age groups, which traditionally in the UK have been very pro-vaccination, okay? And, the other thing is, if you're looking now in the UK, at the moment, I think the UK is administering maybe about 100,000 vaccines a day. But a couple of months ago, they were administering more than 500,000 vaccines a day. And, they have plenty of vaccines. So I think, uptake certainly has slowed down. So people are not rushing forward as much as they were. And the question there is, are the people who are not coming, are they people that say, yeah, no, I'll just wait a bit, or are they people that are just not going to get vaccinated per se?
Thank you for that response. I'm not sure if there's any more questions or
An unpopular question. Any modeling or thoughts on the impact of introducing mandatory vaccination for certain subsets at least? Sorry, I'm a socialist, so this is not going to work. But they're talking about it. Certainly in France, they're now talking about certain groups having to be vaccinated. I don't know what the impact of that will be. You're not going to be able to enforce it for everyone. I think it almost what maybe works better is a bit of a carrot rather than a stick approach. So that if you're saying, well, look, I like traveling, okay, and now what they've done in the UK, I mean, I've had 2 vaccines anyway, but now what they've done in the UK, if you've had 2 vaccines, if you come back from what's called an amber list country, you don't have to quarantine anymore. Well, that's a big incentive. So that's not telling people you have to get vaccinated, but it's just giving that little bit of an additional incentive for doing so.
Very interesting. That seems like a carrot and stick thing. Okay. We are ready. Thank you so much, Stephane.
That's all right. Thank you very much. Thank you everyone for coming.
And thank you everyone.
I will send you the slides, but I just want to fix the couple of graphs at the start, and I'll send you the slides, and feel free to share them with everyone.
Okay. Thank you so much. Thank you.
Thanks a lot.
Really appreciate it. Thank you everyone, and keep safe. Thank you.
Yeah. Bye.
Bye.
Thank you, Stephane.
Thanks a lot. Bye-bye.
Okay.
Thank you.
Bye.
Great presentation.
Mm-hmm.